As people join, if you want to write where you're coming from, your organization, and where you're based out of in the US or you're not in the US, it'd be great to kind of see the diversity of perspectives that we have today. We'll give folks another minute. Thank you, everybody. Let's give people one more minute and then we'll kick off. And for folks just joining, we're putting in name, organization, and where you are in the United States. Thank you, Wesley. Hello, Jen. Good to see you again. Ran into each other at HIMSS just a few days ago. Okay, so we're gonna get kicked off. This is the first in a new series that we're doing with the Center for Care Innovations, who we are thrilled to be working with. So Wesley, I think you are driving the slides. Can we go to the next slide, please? So please keep yourself on mute during the presentation. We're going to have plenty of time for question and answer and discussion after the presentation. At that time, you're welcome to come off mute, off video, show your face, and ask questions. Use the chat if you want to change your name to be your name and your organization. And then Wesley Gabriel just raised his hand, is helping support the webinar. Next slide, please. We're doing a quick welcome of our two organizations, as this is a new series we're kicking off. We are thrilled to have Yasir Tarabichi, Dr. Yasir Tarabichi, joining us. He's going to talk about what it's like to do AI implementation in a safety net hospital, and then we're going to have plenty of time for question and answer. Next slide, please. So the question of why are we doing this, I think in many ways builds off of work we've been trying to do with Health AI Partnership for the last, now we're almost 3 years in, and I think is very aligned with how we've developed the relationship with CCI. And it's really about getting the expertise, the infrastructure capabilities out of the small number of academic medical centers that historically have been the center of AI innovation and implementation. And we expect that in the current political regulatory environment, there's going to be an increased adoption of AI. There's going to be new types of financial pressures. There's going to be deregulation. And ultimately, what we expect that to mean is that folks on the front lines and organizational leaders really need access to information about how to use AI safely, effectively, and equitably. And we see this as a mechanism to at least once a month bring people from the field who are leaders and share insights. Next slide. So just quickly about Health AI Partnership. This is a program that's based out of Duke. At the Duke Institute for Health Innovation is the coordinating center. Our mission is to empower healthcare professionals to use AI safely, effectively, and equitably. We want to advance health equity not only in terms of how individual algorithms are used and perform across subgroups, but also in terms of equipping diverse types of organizations to use AI. We want to advance the use of AI to improve patient care, improve the workplace, and really want to emphasize that it takes a village to do this work. Within any one organization, you're going to be bringing people together with different sets of domain expertise. And then there's lots of collaboration across organizations to share learnings, share insights. Next slide. We're very fortunate to have a large and growing community of core sites that we really lean on as sources of best practices. And that's the perspective that Yasir will be speaking from. He's known in the field, has been an expert in this field, but he also has the position of being in a safety net county hospital. And then we are running a technical assistance program, the Practice Network. Next slide. We try to focus on the delivery organizations, support diverse organizations, bring together different domains of expertise, and provide technical assistance. And then, Wesley, we can skip the next slide and just go straight to Sophie. Sophie, I'll give you a moment to speak about CCI. Thank you, everybody. Thrilled to have you here.
Thank you, Mark. And I'm also so excited to be here. So CCI, Center for Care Innovations, I think many of you have been working with us or been in touch with us over the years, but for you who haven't, our mission is to spark, seed, and spread innovations to advance health, equity, and justice. And our vision is that everyone has fair, just, and inclusive opportunities to be healthy. And that is the definition of health equity. Everything we do is about addressing the deep disparities we have in this country. So supporting the safety net, mainly federally qualified healthcare centers, but also public hospitals, county systems, is really our focus. Can go to the next slide. So when we say that we spark, it is about new ways of working and creating problem solving, creative problem solving. So defining the problem is where we always start, and spend a lot of time making sure we do that by using human-centered design approaches and so forth. And when we say seed, that is the research and de-risking the testing to implement new approaches. And de-risking is creating a safe space, but also working very closely with peers that have done it in different contexts that you can learn along with. It's also sometimes about providing funding to be able to do it within the safety net. And finally, spread. Wes can drop our website, you already did. We have a lot of resources from the safety net over the years. We've been working for 25 years, and a lot of the resources are still relevant and continue to grow. And we accelerate innovation by creating networks. And it's often not new ones. We bring networks together within the safety net and leading technical assistance and training. About 70 to 80% of our work has been in California, but we've also worked across the country. And I want to say it's my real delight to be here with Health AI Partnership, because we're truly mission aligned, and we see today as almost like a shy start. We put this together in a short period of time, but we are committed to do this on a regular basis and just go deeper and build more structure to this, to build this community of you in the room and many of your colleagues in other organizations. And with that, it is my honor to hand it over to Yasir Tarabichi. I'm so happy that you can join us here today. And to everyone, please listen carefully and make note of your questions. Put them in the chat. We want to be able to get to as many as possible during the presentation. And if we can't get to them during the presentation, we're going to do everything we can to have them answered in the coming week. And with that, over to you, Yasir. Thank you.
Thank you for having me. I'm honored to be here and to kick this thing off. I'm going to go ahead and can I swap out the screen for mine? There we go.
Yeah, you should be a co-host now.
Got it. All right, I'm going to do that thing where I'm going to ask if everybody can see me, hear me, even though I can tell that you can. Great. Okay, well, again, thank you. It's an honor, a pleasure. And you guys are seeing my slides, right?
Yes.
I have 3 screens, I have to ask. Okay, so it's kind of interesting because, let me do this again. Zoom doesn't tell you which screen is being shared. Now it does. Okay. So it's, again, honor, pleasure, thank you. I'm going to jump straight into my conflicts of interest here. I do have some funding in the last, bit over a year from Beckman Coulter. Do I hear a question or just getting feedback?
You're good.
Someone's mic is on. Oh, thank you. Okay. I've worked with Beckman Coulter in consultation for some novel biomarkers in sepsis, but this is not the point of this talk, and it's not going to come up. So I'll put that out there. Where this is going, this is really an informaticist perspective on AI implementation through our journey in a safety net system, primarily highlighting two predictive models that we've implemented, and talking a little bit about our learnings, how we approached this, these solutions from an equity lens perspective, or equitability perspective. Talk about the AI practice gap, and then what individual healthcare systems and less well-resourced systems ought to do in this space. A little bit about MetroHealth. We are a safety net healthcare system in Cleveland, Ohio. We're affiliated with Case Western Reserve University, several hospitals, tens of clinics, and pretty diverse patient population. We are, I would say, we generally kind of punch above our weight in terms of IT and IS and informatics solutions. So we do catch the news cycles every now and then with some of our stories. So hopefully you've heard of us from that perspective. So I'm going to start first with our sepsis journey, and let me just kind of frame this. I'd like to get through these slides at a reasonable clip, because I'm really actually more interested in the conversation that we're going to have afterwards. And so this will hopefully frame our perspective enough so that folks can ask questions that we can build off of. And so starting with sepsis, it's always worth trying to re-explain what sepsis is. It's really life-threatening organ dysfunction caused by dysregulated host response to infection. And even in the position paper, it's defined as a broad term applied to an incompletely understood process. And so lo and behold, here we are trying to predict said process. The big real, the tension here with the management of the diagnosis management of sepsis, it's timeliness of antibiotics. And so for the longest time, we've said for every hour that goes by, you don't treat it with antibiotics, patients are more prone to mortality and morbidity. And I think really only true, it's a little complicated, it's really only true in critically ill patients. But the bigger problem in trying to identify and manage sepsis is just frankly ill-defined. And so, the figure there is a figure from Angus et al. That shows really trying to draw lines between organ dysfunction, health, and uncomplicated infection increasingly difficult. And so any model you build or any line that you draw in that space likely going to capture a bunch of false positives, false negatives, and the rest of it, right? So it's hard to predict something that's hard to define that we don't truly, perfectly understand. And, beyond it being just a heterogeneous state, it's also associated with a lot of morbidity and mortality. So, as organizations, we're always tasked with improving our sepsis-related outcomes. I'm going to take us back to 2019. Our EHR vendor puts out a solution, a sepsis early warning system, which is supposed to reduce mortality by as much as 20% or slated to do so. Lots of positive press, no actual peer-reviewed data. And so as an organization that wanted to do better in this space, we thought about how we could approach this problem, pull together a committee from a big multidisciplinary group of clinicians, infectious disease, emergency medicine, informatics, and quality, to think through this problem. And so the very first thing that we do, an internal validation of the model. We turn it on for several months in the background. This was at the time, at least our vendor did not have the ability to retrospectively validate the model. You'd have to do it prospectively, just turn it on and see how it does. And so we found in the space, at least, a sensitivity of 90%, specificity of 68% for a pretty reasonable clinical outcome, death or 3-day ICU stay in patients with suspected infection. And we also found that if we had simulated an alert at a reasonable threshold, that it would fire barely the majority of the time for patients that met criteria for sepsis, so 54%. And so looking at those two, relatively favorable lead time, relatively favorable performance plus a relatively favorable lead time, we thought that there was an opportunity to improve our process. that figure on the right-hand side is one of our control charts that just showed in our simulation how often the alert would go off in our main campus emergency room. And you can kind of get a sense for the fluctuation and just overall number of alerts and how many of those were actually true alerts. And actually not really true alerts, frankly, how many of those alerts culminated in a bad outcome, which is 3 ICU or death. And so it gives you a sense that it is capturing a decent amount of morbidity and potentially mortality in our population. And so here's where I think the biggest problem with any AI-driven solutions comes in. It's how does this fit into our current workflow? And how do we implement it? How do we prove that it works? And how do we measure success, right? And so based on the available data we had at the time, we landed on time to antibiotics being the process measure to target, which in and of itself kind of a process measure that approximated the potential mortality benefit in sicker patients. And because we were talking about delivering antibiotics, the very next thought was it had to be pharmacists embedded in the workflow. And so when we thought about how clinicians and care teams responded to sepsis, we thought, well, somebody suspected sepsis. A response to sepsis was requested, which included doing things like labs, right, cultures, fluids, antibiotics. And then that response would be mobilized by just different team members in different capacities. And so we thought an early warning system really could hasten the overall process, but we really frankly thought that it wasn't going to affect clinician judgment as much because clinicians tend to know or feel if their patients are septic. And we thought that really it was more likely to hasten the actual response, meaning what other organizations typically call like a code sepsis, depending on what you do at your site. And so putting all that together, we thought pharmacist is going to be in the middle. We thought, how can this alert potentially catalyze our response to sepsis? We drew a swim lane diagram, which led with, if you suspect sepsis, diagnose and treat sepsis. If you see an alert, consider sepsis and then continue with that same clinical workflow. And thinking through this evaluation mechanism, well, how are we going to prove to us that this works in our setting? What we know is, really this is a process-focused, low-risk intervention. There are various signals from other organizations about whether or not it works. We didn't know if it was going to work in our setting. We have limited resources, and so we have a part of a pharmacist because, of course, our pharmacists are doing a lot of things in the ED setting. And really, this particular intervention was part of a subset of a larger QI improvement process for sepsis. And so where I'm getting at with all of these points, if you're following, is this makes a really good case for a randomized quality improvement initiative. And I would say, and really asterisk brackets, parentheses, in conjunction with careful oversight, of course, from the IRB, ethics and quality leadership. And I like this work, that middle segment's work from NYU that talks about how healthcare systems implement interventions like this wholesale because they seem like good ideas, but they rarely formally evaluate their effectiveness. And we do these like really terrible before and after analyses, look at secular trends, selection biases that creep in, and regression to the mean, the rest of that sentence. And the real idea here is, as a learning health system, at least if we're thinking about the framing of a learning health system, when we implement these solutions, we really ought to think about them in terms of measuring the actual impact at our local setting for our patients and our providers. And so that last piece on the slide there is an editorial that came out with our publication that talked about really the overarching kind of ethical construct here of when is something research, when is it quality improvement, and what do you do somewhere in between? And it's fair to say that learning health systems and quality improvement research is definitely in the in-between zone. So obviously approach these problems with caution. Once we were given the go-ahead to do a prospective randomized controlled intervention, we baked the randomization feature into the electronic health record. So patients that came onto the emergency rooms, all the patients coming into the emergency room would be triaged to either have an alert if they met sepsis or be in the group that doesn't have an alert if they met sepsis. And for patients that met the sepsis alert threshold, we would display their alert on a track board and notify the pharmacist, which again, we thought would be the key to the intervention. And so the track board, for those of you that don't know what happens in an emergency room, the track board is where ED clinicians look to see overall who's in my ED, where are they going, have they been triaged, do they have a destination, what's outstanding. And so we thought it was a really nifty place to just kind of drop an icon there. And that was it. There's no interruptive alert. The pharmacist got a little bit more information about when the alert would go off. They could click on the message and get a little bit more insight into the situation. And so in turning this thing on, we ran that simulation data for a decent amount of time in 2018, thought through the building and the planning process in early 2019, implemented our solution over the course of several months towards the end of 2019, and basically hit a pause because of COVID. And this is a picture that I show because kind of gives you a sense of what was happening in healthcare systems at the time. I had a lung cancer screening decision aid study in the outpatient setting that ended up being a holster for masks and for COVID masks, frankly. And so we were not able to publish our experience immediately, but we had reasonable data to suggest that we should keep moving forward with our intervention, our implementation, I should say. Before we were able to publish, we actually had this paper come out from University of Michigan that basically made the case that in isolation, the EPIC sepsis model, version 1, not very good. We were quoted in the Casey Ross, the infamous Casey Ross article, the study and the article that everybody liked to cite about how terribly EPIC was doing in the space. We were quoted in actually producing this prospective randomized study and how we had results that were not yet published. But I think this is where I wanted to be careful about what I said. And this is the latter part of that segment. Our experience, which is a robust study design, led us to conclude that this was helpful in our patient population, and it's still on, despite the results of the prior study. And so I said, I'm not turning around and saying, hey, this is fine, everybody use it, but what I'm hoping to develop is a roadmap for the implementation of predictive analytics. And really, this probably should have said predictive analytics at the local context and safety net systems, and I think part of the broader conversation we're hoping to have today. So ultimately, we were able to publish the study, and it's worth pointing out that for our results, I don't want to spend too much time on this, but we improved timeliness of antimicrobial administration in the ED setting by a little under an hour, which I think, obviously it's not uber impressive, but not a whole lot of time to improve that metric when the control group was 3 hours. And we also tied that to a overall clinical outcome of days alive and out of hospital and saw an improvement in that in the intervention group. And so when we saw this being a quality improvement initiative, as soon as we saw this, we said, you know what, this is working for us in our local setting. We really ought to turn this on. Some of the additional results that supported the value of this model, we saw that the intervention group had a shorter time from alert to an antibiotic order. So it means it may have actually triggered clinicians to order antibiotics faster. And we also saw that the time from order placement to administration was hastened. So again, multiple aspects of the response that seemed to be affected by this intervention. And so why do we think that this was right for us? Again, in the context of a study that in isolation said, this model is not useful. Well, we did an internal validation, and that bred confidence amongst our stakeholders. We involved our stakeholders early in the discussion, and they molded the intervention. So a lot of the steps that we took in the ED were driven primarily by how the ED felt they could use our intervention, use our model. The alert was simple. We thought it was integrated in an obvious workflow location. We fought the urge to show numbers. We went for an all or none alert. We can have this conversation about, showing percents and even explainability. We focused on the ED setting where sepsis is more prevalent. For those of you thinking about turning on sepsis models on the inpatient side, that's a much more difficult proposition. And I think one of the crucial aspects of our intervention was we knew who could use this information best, and we thought pharmacists were the right ones for that. So they were the sepsis response champion. And so my takeaway from all of this, because the C-statistic for the model is not impressive, frankly, is it's not the size of the C-statistic that matters, it's how you use the model. And I think this has become increasingly true in the healthcare space. So we published an editorial back in 2021 based on that very same notion. And I'll say, fast forward to now, and this is Chris Longhurst at UCSD making the same case, which is the secret sauce, 78% is actually all of the local context. And so taking this out of the informatics playbook, the whole idea behind these solutions, even if it's generative AI or predictive analytics, it's person plus AI, computer, CDS, whatever have you, better than person alone. And so thinking about that University of Michigan study in isolation, looking at how the model performs from an AUC perspective, without pairing it with a clinician, not as useful a comparison to make. It looks at the model in isolation. So you're not asking for the model to diagnose sepsis. You're asking, how does the model inform the diagnosis and management of sepsis? So I'm going to bring us back to some more core informatics concepts, which are, Bates' 10 Commandments. And the ones I highlighted are the ones that I thought we really spoke to in the intervention. So we delivered this in real time. We fit it into a nice place in the workflow. Usability is important. We made this really unobtrusive. We didn't make people put in data when they didn't need to. And then simple interventions work best. Ask for information only when needed. And we obviously monitored this in real time, got feedback, and we were poised to pivot if and when needed. So the nice thing about the conversation that I had with Karen Deep at University of Michigan at the time was, well, maybe there's something to what we found in our organization. And so they looked at looking at different healthcare systems and looking at the performance, again, isolated model performance across different healthcare settings to determine how well the model did in different settings, and found that there was a large degree of variability in the C statistic between different organizations. And in smaller, more community-based organizations like ours, the model actually seemed to perform relatively well. And so that was encouraging for us. And so how do we keep improving from there? Well, we continue to monitor model performance and time to antibiotics, looking for drift and shift. We validated the next version of our EHR vendors model, which is a locally trained model. So it moved away from some of the other limitations in the first model. We actually ended up hiring more pharmacists because we realized that was a value add. But I'll just say kind of subtext here is what we really needed were more providers. At some point when I asked our pharmacists, how can we go faster? How can we make this better? They were telling me that they're running around in the emergency room with bags of antibiotics looking for somebody to help them administer. And so sometimes the hang up is not, I know it's not, I didn't know that it was sepsis or I missed something. It's more practical. And we worked on education and addressing explainability. And I think we'll maybe talk a little bit about that in the after this the slide set. So a follow-up to the sepsis models, the second version, this is a conversation, continued conversation with the Michigan group here about the value add of the model. And the question being posed in this paper is, does the model know somebody had sepsis too late in the process? And the finding they had was really, if you looked at early predictions versus predictions after an antibiotic was administered or something like a lactate was measured, indicating the possibility of sepsis, that the performance of the model depreciated over time, frankly. Or I should say it's the other way around. The model looked better. I take that back. The model looked better further along in the course of a hospitalization. And so I have some data to talk through how we handled that with the next version. But in implementing version 2, we worked a little bit more on explainability. We even produced a model facts based on a lot of the interest in that at that time. I'd say one of my biggest hangups about the explainability aspect on the practical level is clinicians really struggle. I mean, I do think they're Bayesian in thinking. I think they can be probabilistic, but they often veer more on the mechanistic aspect. And I think Chad's VASC is a really great example of that, where we live it because it makes sense. But when somebody gives you a prediction, like, here's your risk of readmission, well, it's driven by the number of active orders. So if the number of active orders predicts the readmission risk, does that mean discontinuing orders reduces the risk of readmission, right? That's the kind of conversation you have to have with your providers as you make sense of these models. Another one that's obvious is, well, a priest predicts death, and that's explainability, sure, but that's not useful information. And so the other aspect of explainability that always makes me nervous is it can engender misplaced trust, even if the recommendation of the prediction is wrong. And that's the illusion of explanatory depth. And so there's been a good amount of research in this space where the AI solution, because it looks like it could explain something really well, we're prone to believing it, even if it's intentionally wrong, right, for the purposes of the study. So that was our sepsis journey. Our no-show mitigation journey is, I realize I dropped the slide at some point, but we can keep moving. Similar conversation. We have a major no-show problem in a safety net healthcare system. In our own internal medicine clinic, during that time frame, 18.9% no-show rate for whites, 28.2% for Black patients, and 25.7% for Hispanic patients, which I would imagine is mirrored by other organizations that have a similar patient makeup. And so one of the potential issues that are typically floated in this context are really, can we just do more overbooks, right? Let's game the system. And obviously, not a great outcome here, right? So this was a solution that was implemented early on at our organization. I have high-level details here just to share, but it was a vendor-driven solution that predicted the risk of no-show and actually overbooked patients that are high risk on a shadow schedule. And the long and short of it is it was deemed an operational failure because it didn't hit the expectations of the, the executive group that implemented it, mainly in that really it seemed pretty good to me, actually. 60% of the time, one patient was present, but a third of the time, both showed up. And it kind of feels like there was an opportunity to maybe recalibrate or reset the thresholds to try to achieve less of the double patient show rate. But this is the issue of a lot of these, solutions. They don't explain everything, and you're going to have this wide interval of, well, there's a possibility of two people showing up. And so the net outcome here is it was deemed an operational failure, overly expensive. And I think it kind of, it created enough trouble when two patients showed up that it was deemed an operational failure. And so my caveat to that whole conversation in the access space, and this is very important for us as a safety net system, is that in a zero-sum game, those that are already behind are poised to lose. And this is a great simulation study, highly technical, so it's kind of hard to extract the clinical insight here. But the main idea really is that you can optimize a model to pick patients for overbooking based on just purely reducing the no-show rate or trying to equitably reduce the no-show rate. And doing so can improve your no-show rate equitability, but it will not do so to the point where you're gonna be operationally efficient. So what I'm trying to say is using something like a race-aware function, it'll reduce waiting for racial groups most likely to wait. Optimizing for reduced wait times and those expected to wait longest is not as effective. And so you have to think about what are you building your model to achieve? And I think this is a figure that those of us that live in this space look at a lot. How can we solve for access equitably? My argument, do not overbook. I think protect a patient's opportunity to show up. And given limited resources, I think the idea here is if we're trying to do anything on top of that, what is the opportunity? It's really adding resources and adding resources to those that are at greatest risk of not showing up. I think that's a very reasonable model. That gets you closer to that equity construct. And the most important thing is, if you're intervening in this space, you absolutely have to closely monitor to make sure you're not, that you are improving disparities as opposed to widening them. So our journey with the no-show model, which is also an Epic integrated solution. So it's a vendor, it's a vendor generated random forest model. It's trained locally, over 30 variables. The cool thing about this model compared to some of their early architecture was it does train on retrospective data. It's trained and cross-validated in the cloud. They send you back your information. This is how your model performs. So for us, it had an AUC of 0.8, which we thought was pretty reasonable in the space. But beyond that, we chose to prospectively validate this for another 90 days with over 500,000 visits in our system. And particularly for this model, obviously, we were concerned about, is the model fair? Does it make good predictions for all of our patients? And this is just a sampling of some of the calibration plots that we put out, which, looked at differences in how the model performs and our white subgroup versus our black subgroup, for instance. So not perfect, but, we thought reasonable to start with. And this is when our second big model implementation, we started to develop our ad hoc intake and governance process. And, we're thinking through AI governance at this point, like other organizations were. Obviously, we've matured now to the point now where we actually do have an AI advisory committee that is a permanent multidisciplinary group that looks at AI solutions that are coming into the organization, both clinically and operationally. And so this started to introduce the notion of, how do we vet this? And who actually understands how to vet this? Who understands the risks that we have to mitigate along all of these kind of work streams, be it, InfoSec, be it clinical responsibility, be it operational efficacy, right? And so that, really, when does it end? Which is an important aspect of the overall conversation around the AI product lifecycle. For this implementation, we had a similar question. We said, what can we do to implement this into a process, to drive a process, to improve outcomes in an equitable fashion? And so it had to be an integrated product. It had to be an integrated solution where it baked into a current process, informed the process. Somebody have a question? Let me know if I'm, yep, okay. I think people are chatting things, but I think Mark already set the expectation that we're gonna have the conversation afterwards. So I'm gonna keep going here. So we looked at where our support staff would call patients, to remind them about a visit. We looked at a pre-existing screen, and we basically engineered the screen to rank people based on risk of not showing up. And for the purposes of our intervention, decided to randomize the group of patients that they were calling. And so we knew that they were not going to we knew they would not be able to call all patients on the list. And so we thought, again, stratifying by risk and the randomization made sense for a prospective randomized controlled quality improvement initiative. And so that's the conversation here. So we set the threshold at 15% chance of no-show. Our primary outcome was the overall no-show rate, looking specifically at stratification by race and ethnicity, because equitability was our primary outcome. We looked at calls completed, call outcomes, and some of the balancing measures, thinking about just from a QI perspective, what are the things that could go wrong in the space, reschedules, no-shows, or what we call teleflips, which is taking an in-person visit and turning it into a virtual care visit. And so we reviewed this on a regular basis. Again, quality improvement. So we weren't trying to figure out what it looked like at the end. We wanted to know how it was doing in real time, and we were interested in iterating. This time we went a little bit faster because we were able to train the model on retrospective data, and because there wasn't COVID part 2 at this point. And so we were able to get this going. This is the result of that work. So this is the study. I'll go briefly into the outcomes, which I think are interesting. So we were able to reduce no-show rates actually overall, and I think I may have missed a slide. We were able to reduce no-show rates overall, but the biggest improvement in no-show rate was a 15% reduction in our Black patients. Some of the subtext and some of the data that we looked at for secondary analysis showed that we were actually able to connect with those patients the most. From a cost-benefit analysis perspective, I know one of the questions that came up, before this presentation, how do you make a case for the cost effectiveness of AI solutions from a safety net system perspective? We had to come up with, well, how many people did our PSRs have to call to prevent a patient from showing up? And so the number needed to call for our intervention for the threshold that we set was actually 30. And it kind of makes you wonder, right, in terms of, well, how much time is out of an individual person's time? Could they be doing something else? But it's, I think I would argue a 15% reduction in no-show rate in a minority group in a safety net community system is probably worth paying for. So if that's 30 minutes or an hour of someone's time, we thought it was worthwhile. The other conversation that came out of this, and I think this is really important, so this was not so much cart before the horse. We knew that there was an opportunity to bake a no-show model into our outreach process. It was a logical thing to do. But the question is, are we predicting the right thing? So in the context of the no-show model, what we found was there was a subset of patients that were more likely to answer a human phone call than they were to respond to patient portal pings or robocalls. And it gets you thinking, would it be better to identify patients who are more likely to respond positively to a certain outreach mechanism than really trying to predict who's not going to show up? Now, those things may correlate at some point, and I think that's what we picked up on our study, but they're obviously not the same thing. And so what this gets you thinking about, just from an informatics perspective, is, are we using smart technology to fix broken systems and broken processes? And I think, frankly, likely. Right? I think that's one of the biggest issues we have. I think AI in this context has accelerated the need to evaluate our infrastructure and our solutions. But at the end of the day, is AI really what we needed, as opposed to the opportunity that it presented to reevaluate our structure? So taking a step back with those two use cases, from a safety net system perspective, the question that comes up is, how can individual systems ensure responsible AI implementation? And we talk all the time about the AI chasm, which is tons of money, time, money, and energy, pouring into solutions that are supposed to save and disrupt healthcare, But if you ask the average clinician today or the average provider today, they tell you they're not really seeing that, short of maybe all this noise about ambient AI. I think some of the biggest barriers are really we don't have good ties to clinical outcomes data. And so from the sepsis perspective, tons of articles published on I can predict sepsis, but very few on the so what, and what are you going to do with it, and how are you going to use it at the local level. And I think this is a unique perspective from the clinical informatics realm, which is really implementation is hard. And there's an intersection of multiple disciplines that make informaticians good at what they do. And a lot of that is understanding the socio-technical complexity, change managing control of the space and the process that they're trying to improve. And I think taking this kind of outside the healthcare system, and Mark alluded to this at the outset, I don't know that current regulation or deregulation is not going to solve for this. So I do think good predictions matter. Do we need a dedicated agency to tell us what's working, what's not? Sure, that could be useful. But we need to think about how to tie those to outcomes at the local level. And so obviously what comes to mind here is, this flurry of AI assurance labs that have propped up. So typically private-public partnerships, and they're supposed to be evaluating models using quote unquote nationwide standards and best practices. And it's great that we have independent third-party validation. But of course, from a safety net perspective, I suspect that several large academic centers have biased patient representation sampling. I'm always curious about who's paying for what, right? Follow the money. And I think even for the proposals that I've seen so far, we get back to the issue of validating a model in isolation. And so let's focus on what the model can do in the hands of somebody in the right setting, and more on here's how the model does from a pure, AUC or calibration perspective. I think this is, a shout out here to Mark for mentioning our work at MetroHealth. AI assurance labs can leave at-risk populations behind. So this notion of trickle-down assurance. So same point I made earlier, the moment you put an AI technology on the front line, it becomes a socio-technical system. And so thank you, Mark, for mentioning our study in this the Stat News article. This notion of practice heterogeneity it's obviously not new. So this is a great, on the sepsis conversation, a great article about time to antibiotics in several different healthcare systems from a VA cohort. And you can see how much variability there is in practice from site to site, and also from era to era. And so you can't tell me that a sepsis model is going to behave the same in each one of those settings. And I think this is where we get in the conversation where, frankly, localization matters. And so I would posit that algorithmic bias is not new, nor is it relegated to artificial intelligence. And so these are models that predict the likelihood of a poor cardiovascular outcome, which are used in care. And this is our local group showing how the plots, that's how the models tend to under predict the risk of a cardiovascular outcome in patients who live in less affluent neighborhoods, which is a serious problem, because if we're making prescribing decisions based on this, obviously that's hugely problematic. And so I do think smaller systems have to do this work. And the problem with smaller systems is we have fewer resources, immature tools, and limited expertise. And I think better tooling can reduce the cost of the validation and maintenance. So I think a lot of our vendors are starting to understand this. Better tooling also makes the data science more accessible. So I really like the idea of a light quant. So I like the idea that figure on the left is the kind of amorphous learning health system concept of who's living in the EHR and the healthcare world, and who's living in the data science and the research world. And how do we bridge the two, right, to have a meaningful impact in the space? And in my mind, people that understand all the complexity of moving through the health records, health information exchange, clinical decision support constructs, reaching up to understand the data science enough to implement AI solutions at the point of care are going to have much bigger impact than someone who understands the data science and is building a model, cart before the horse. And so I'm in huge favor of this notion of light quants, the analytical translators. And I think from a clinical informatics perspective, I think that's the workforce that we need to upskill to get to that point. which brings me to, my shout out again to Mark for the Health AI partnership. Now, this is where we participate, collaborate, and understand how we are building this AI implementation readiness in less well-resourced sites. So beyond, working together to understand that roadmap, the next question is really, how can individual systems contribute to responsible AI development? And I would say it's old solutions to new problems, interoperability, and I'm going to go through this really quickly. Garbage in, garbage out. If your data is living behind a closed system, we live in silos, it's not interoperable. At the end of the day, attempting to standardize your data so that if a model comes in, you can actually take advantage of it. And standardizing your data so that there's an opportunity there for federated learning. I think that's one potential mechanism for systems to do this. And I'm going to jump to this to say, we've done this by pushing a lot of the emphasis on that interconnectivity and interoperability back on the EHR vendors to say it really ought to be your job to bring this wealth of data together so that we as an organization and we as a community can benefit. So I really think that the prospect for federated learning on initiatives that, again, push the emphasis and the effort back on the vendors that got us here in the first place, I think that's really a very reasonable way forward in terms of contributing to this ecosystem. And so I'm going to jump here to my conclusions. I think people and process, hopefully this is highlighted through our work, people and process are more important than tech. And I think informaticists and implementation scientists and even quality leaders love this. A true local impact of a model can only be realized when it's implemented. I think with effective EHR utilization and oversight, randomized QI interventions are an efficient mechanism that can objectively inform local process improvement. I think local governance cannot be outsourced. That's a huge risk there. Improving the quality of data at the source and building on interoperability, I feel, is the most impactful way forward for federated AI assurance, regardless of how we choose to do that. And I think mature tooling with analytically savvy clinical informaticists can go a long way to scaling AI solutions in all settings and regardless of resources. And so I will leave it there, and I look forward to seeing the chat here and get this conversation going. And thank you.
All right, thanks, Dr. Tarabichi, for this presentation. I'm Jessica Ortiz with the Center for Care Innovations, just going to help with facilitating the Q&A. I see a question from Wesley McPhee in the chat. What impact, if any, did your hospital system experience pre and post implementation with your sepsis model versus your overall CMS SEP1 quality measures performance?
Oh, that's a trick question. I like it. So I'm just going to say that improving timeliness of antimicrobial administration is not guaranteed to improve your CMS metrics. This is a very disclaimery way of putting it, but this intervention was part of a bigger quality improvement initiative. We have other things that have contributed to a reduction in our observed sepsis, observed versus expected sepsis mortality. And we have other more kind of mechanistic ways to handle the CMS requirements. So we've been doing better in the report from the reporting perspective. And this model is really only a piece of that. But how's that for a non-answer?
We've got another question from Christy in the chat. Any thoughts on the role of nurse scientists, nurses with PhDs?
Yeah, absolutely essential. Do not want to ignore, I think we have, I think I saw our CNIO jump on at one point. We have a strong nursing leadership. We have CNIOs, and we cannot bring forward a solution without somebody in another, somebody on the nursing side saying, well, how is this going to help enterprise-wide? How is this going to feed the nursing mission, right? So I think having that kind of diversity and perspective, super important. I think one of the best things about our setup is we have a lot of voices, and even from the business side. So we often kind of get constrained. Like, I'm an intensivist, so I'm thinking sepsis is the most important thing in the world, but operationally not true. right? I would say our work on no-show in a primary care setting is likely more impactful.
Our next question is from Christopher. Let's see. Did you have any concern along the way with gag clauses?
Yeah. All right. So another one to kind of tiptoe through here. So I'll say that more often than not, when we work with our EHR vendor, as long as we are clear in our intent and as long as we are being productive, they have been very responsive. I think in general, I'm going to say the Epic community, just to call it out because it's already been said, right? So the Epic community, very cooperative and very interactive. And so we talk to each other at conferences, both Epic and non-Epic conferences, and we cross-pollinate. And so I'll say part of the work that we're doing with HYPE, HAIP, it's working with actually other Epic shops who are thinking about the same exact models. And the answer is not, is the Epic model good or is the Epic model bad? It's what can I do with the model and will it help me at the local level? So what are the lessons learned? You know, show me your scars. I don't want to repeat your mistakes. Let's collaborate. So I would say it's generally collaborative. And I would say as long as you approach that, again, open-minded and you're clear about your intentions, we were able to publish everything that we could about the sepsis model, you know, after speaking with Epic and just telling them what we're up to. And they were less interested, frankly, about the results. I mean, they were interested in the result, but they were not going to kind of limit the release of information based on the outcome of our study. They wanted to be helpful. I think, just to be frank, at the outset, there was a lot of thinking that the value proposition of these solutions is the actual proprietary nature of the model. But I will tell you that everybody who's predicting sepsis is using the same, you know, 20 to 30 variables, and you can swap them around, and I think the outcome's likely ultimately going to be the same. So it's not about the model, really. As a vendor, you have the ability to bake it into a process within your software, and I think that's your secret sauce. That's your moat. And so I'm not saying that, you know, everybody should go use Epic. I'm just saying that, frankly, the model's less exciting at this point.
Mark, I see your hand up, and we've got 2 questions in the chat in a few minutes. Did you want to make it?
Yeah, I want to take it in a little bit different of a direction, because I feel like in the safety net, there's a lot more collaboration between payers and providers, whether it be a Medicaid agency or a health plan. Managed care is increasingly common in Medicaid. So I'm curious, Yasir, what's your perspective for people on this call from the payer side?
Yeah, I mean, we work closely with our payers. I mean, obviously at Metro, we have a large contingent of employees who we have on a plan. I mean, we're at risk. We talk. We absolutely have to talk. And so I don't see those walls as being useful. And I'll say most organizations, most payers, they're open to discussion. They're open to having these conversations. I mean, they're wanting to send us our data back, right? They're wanting to help us improve and derive more value in our care for these patients. So I think it's been a positive relationship, frankly. I haven't had any trouble there.
We've got 2 last questions in the chat, and I think they overlap.
Yeah.
Did you want to talk about light quant?
Yeah, light quants. Yeah. So it's a really good point. Really good question, I should say. In the field that I live in informatics, a lot of it is administrative, leadership, change management. It's all very important stuff, but there's not always an emphasis on the data science aspect of things. I think that there are enough numerically savvy, tech savvy individuals that are in this field that can be educated quickly enough to lean into the space. And so I'm going to go back to the tooling that I mentioned earlier. So, you know, if we at large identify the kinds of things we need to measure in the context of deploying and monitoring these models and these interventions, I think you can upskill somebody who's got that numeric kind of savviness enough that they'll be able to manage this. I don't know that we'll ever get to the point where it's going to be automatically, you know, like maybe at some point it'll tell you exactly what you need to do. I mean, obviously that was the goal. But in the space that we're at, I think we need to own it. And so I think the spoken hub model of the Health AI partnership is a really good way for organizations to talk, collaborate, and mentor each other in the space. So I'm not going to go and propose like everybody needs to go get a master's or a PhD. So you've already done enough school as a clinician or a nurse to then add to that. Obviously, it'll only add to your journey, but I think it's again less about can I build an AI solution and more about what is it about a solution that I need to understand to implement it in my space. So your core value proposition is understanding the space, less about understanding the model.
Great. Thank you so much, Dr. Yasir Tarabichi, for this presentation and answering all of the questions. We did get through the questions. And I'll also say there were quite a few questions related to your presentation that were in the registration that you covered in your presentation. So thank you so much.
Yeah.
I'm going to quickly, just before everybody hops off and goes on to the rest of your day, let you know what we have coming up. So this is our inaugural session for our AI in Action series. And so this will be a monthly series. We are planning for April, so stay tuned for the date. I believe there's a couple of registration links in the chat for you to click and follow up on. But I wanted to make a plug for our upcoming webinar, co-designed by CCI, Health AI Partnership, and Alliance Chicago, navigating the AI landscape for the safety net. This will be a 90-minute webinar. It'll include an overview of some current frameworks, just a landscape analysis of the key stakeholders and their interests in this area, as well as some key resources and a panel that we're planning for you all that will represent provider voice and some subject matter experts in the space of AI. So we look forward to seeing you there, as well as seeing you next month for the next AI in Action series. Wesley put another link in the chat for our survey to give us some feedback on the session for today. Wishing you all a great rest of your week, and we'll see you next time. Bye, everyone.